Pregnancy is one of the most exciting journeys in a woman's life. But when diabetes enters the picture, it can feel overwhelming. Whether you're managing type 1, type 2, or gestational diabetes, this video will guide you through the science, risks, and practical tips to protect both you and your baby. According to the CDC, nearly 10% of pregnancies in the US are affected by gestational diabetes. With rising rates of obesity and insulin resistance, the number continues to grow worldwide. There are three major types of diabetes to understand during pregnancy. Type 1 diabetes. An autoimmune disease where the pancreas produces little or no insulin. Women with type 1 require insulin therapy throughout pregnancy. Type 2 diabetes. A chronic condition characterized by insulin resistance. Often linked to weight, age, and genetics. May require insulin during pregnancy. Gestational diabetes mellitus, GDM. This develops during pregnancy, usually after 24 weeks. It affects how your cells use sugar and is caused by hormonal changes and insulin resistance. Globally, about 1 in 6 births is affected by hyperglycemia in pregnancy, according to the WHO. Uncontrolled blood sugar can have serious consequences. For the baby. Macrosomia, large baby, complicated delivery. Neonatal hypoglycemia, low blood sugar after birth. Preterm birth. Higher risk of developing obesity and type 2 diabetes later in life. For the mother. Preeclampsia, dangerous high blood pressure. Risk of C-section. Urinary tract infections. Long-term risk of type 2 diabetes, especially with GDM. Studies from the NIH show that tight blood glucose control reduces complications by up to 40%. During pregnancy, placental hormones like human placental lactogen, HPL, and cortisol increase insulin resistance. Normally, the pancreas compensates by producing more insulin, but if it can't keep up, blood sugar rises. In gestational diabetes, insulin resistance increases by 50% to 70% during the second and third trimesters. This explains why GDM often develops late in pregnancy. The HAPO study, Hyperglycemia and Adverse Pregnancy Outcome, involving over 23,000 women, showed that even mildly elevated glucose levels increase the risk of complications. Managing diabetes during pregnancy involves three main pillars: monitoring, nutrition, and physical activity. Blood sugar monitoring. Track fasting and postprandial, after meal, levels. Target fasting glucose should be below 95 mg per deciliter, and 1 hour post-meal under 140 mg per deciliter. Diet. Low glycemic foods, fiber-rich meals, balanced carbohydrates, and proteins. Limit sugary drinks and refined carbs. Exercise. Light activity such as walking or prenatal yoga helps increase insulin sensitivity. Medication. Insulin is considered safe in pregnancy. Some oral meds like metformin are also prescribed but with caution. Regular ultrasounds track fetal growth. If the baby is too large, doctors may recommend early delivery. Non-stress tests, biophysical profiles, and amniotic fluid assessments may be conducted weekly in the third trimester. If complications arise, a planned C-section may be advised. The key is close collaboration with your OB/GYN, endocrinologist, and dietitian. Labor is carefully managed to avoid spikes or drops in blood sugar. Insulin may be administered during labor. Post-delivery, most cases of gestational diabetes resolve. However, about 50% of women will develop type 2 diabetes within 10 years. A follow-up glucose test is essential at 6 to 12 weeks postpartum. Breastfeeding can help normalize glucose levels and reduce long-term risk. Diabetes during pregnancy requires extra care, but you're not alone. With proper management, education, and support, you can have a healthy pregnancy and a healthy baby. Subscribe for more evidence-based women's health content.